Welcome to this video on managed care. We will explore how insurers, providers, and patients balance cost, quality, and access in the modern healthcare system. Managed care is a healthcare insurance approach that actively manages how care is delivered. It involves controlling access, coverage scope, payment methods, and resource utilization. The core goal of managed care is to maximize value. This is achieved by controlling costs while maintaining or improving the quality of care. Every managed care system is built around four key players: enrollees, providers, MCOs, and sponsors. Their interactions shape how healthcare services are delivered. Managed care has become the dominant model in the United States, with approximately 85% of Americans enrolled in a plan. Looking back at the year 2000, private insurance, Medicare and Medicaid, were the foundational programs shaping healthcare access for Americans. Medicare provides essential coverage for the elderly and those with specific health conditions. It is divided into four parts, including the managed care options found in Part C. Medicaid is a joint federal and state program designed to provide healthcare for low-income citizens, acting as the nation's largest safety net health program. Before 1965, the healthcare system relied on cost-based retrospective reimbursement, where insurers paid whatever costs hospitals reported for services rendered. Starting in the late 1960s, healthcare costs rose rapidly due to factors like advancing medical technology, increased physician fees, and new pharmaceutical developments. A structural quirk in the system was third-party payment, where the patient, provider, and payer were three distinct parties, leading to increased costs and moral hazard. Over 60 years, national health expenditures have grown significantly, consuming an increasingly larger share of the country's GDP. By the early 1980s, rising healthcare costs were threatening American economic competitiveness, prompting both employers and the government to push for change. The government introduced the prospective payment system in 1983, which replaced cost-based reimbursement with fixed payments tied to diagnoses to control costs. Diagnosis-related groups, or DRGs, provide a classification system that allows Medicare to pay a single, predetermined amount based on a patient's diagnosis and expected resource use. Over 4 decades, the healthcare landscape shifted dramatically, changing how care is organized, financed, and how systems compete for members. Managed care organizations utilize two primary tools to keep care appropriate and control costs: gatekeeping and utilization review. The gatekeeper model shifted the patient journey. Instead of direct access to specialists, patients must first coordinate care through a primary care physician. The primary care physician acts as the gatekeeper, serving as the personal point of contact for common specialties like internal medicine, pediatrics, and family medicine. For the costliest patients, MCOs add case and disease management tools. This acknowledges that a small share of members often drives a large portion of overall spending. To manage rising pharmaceutical costs, plans implemented tools like formularies, tiered copays, and pharmacy benefit managers to incentivize cost-effective medication use. Provider payment methods range from fee-for-service to capitation. Each method represents a different way of distributing utilization risk between the payer and the provider. Capitation shifts incentives by paying a fixed monthly amount per enrollee. This makes prevention and efficient care delivery financially advantageous for the provider. Health insurance provides protection against unexpected costs. In the group market, this money flows from employees and employers into a pool managed by the insurer. Group plans often win over individual ones because they provide better pricing through larger risk pools and reduce administrative burdens for employees. Larger employers can offer multiple plans, allowing individuals to choose between high-option plans with broader access or low-option plans with lower premiums. Cost-sharing is a key mechanism for managing demand, using deductibles, copayments, and coinsurance to require patients to have skin in the game. Evidence shows that when patients share costs, they often make more thoughtful decisions regarding their healthcare usage, generally without causing harm to health outcomes. Managed care operates on a spectrum, from less restrictive indemnity models to more controlled, closed-panel HMOs, which offer higher cost containment potential. The transition from traditional indemnity to managed care models was rapid, fundamentally reshaping the U.S. insurance market between the late 80s and early 2000s. We begin our look at plan types with traditional indemnity insurance, the classic model where patients choose any provider. The insurer reimburses based on a fee schedule, offering maximum freedom, but historically, this also meant maximum costs. Next are health maintenance organizations, or HMOs, which were the pioneers of managed care following the HMO Act of 1973. A defining feature is their in-network only requirement, meaning out-of-network care is generally not covered. HMOs are unique in that they are built around prevention. They are the only major plan type that financially encourages wellness visits, typically featuring no annual deductible and lower copayments compared to other plans. HMOs come in two main flavors: open panel and closed panel. Open panel HMOs work with independent contractors who maintain their own practices, while closed panel HMOs use dedicated physicians who work exclusively for the organization. Beyond open and closed panels, there are four classic HMO models: the staff and group models, which are closed panel, and the network and IPA models, which represent hybrid or open panel approaches, respectively. However, HMOs have a primary drawback: they are the most restrictive plan type. To control costs, they often require a primary care gatekeeper, pre-authorization for procedures, and strict adherence to their provider network. Preferred provider organizations, or PPOs, act as managed care's compromise. They offer a network of providers with discounted rates, but unlike HMOs, they still provide coverage for out-of-network care, giving members more choice. The trade-off for the PPO's freedom is cost. While HMOs use gatekeepers and networks to keep premiums and cost-sharing low, PPOs allow members to pay more in premiums and coinsurance for the flexibility to go outside the network. Point-of-service plans, or POS, serve as a hybrid. They maintain an HMO core where in-network care is most affordable, but they offer an escape hatch, allowing members to step out of network for a higher cost at the point of service. By the late 1990s, the managed care backlash occurred as patients and physicians pushed back against tight networks and denied care. This forced plans to loosen their controls, leading to a shift in market share toward PPOs. To ensure quality amidst these changes, the NCQA emerged to accredit health plans using standardized datasets called HEDIS. These, quote, report cards allow buyers to objectively compare plans on metrics like screenings and chronic care follow-up. In the 2000s, consumer-directed plans gained prominence. These combine high-deductible health plans with tax-advantaged accounts like HSAs, aiming to make members more aware of healthcare costs by using their own funds. Managed care has since evolved into value-based care. The focus is now on outcomes rather than just utilization control, using tools like pay-for-performance, accountable care organizations, and the significant expansion of Medicare Advantage. Ultimately, all plans are just different combinations of demand-side levers, like cost-sharing and gatekeeping, and supply-side levers, like negotiated rates and utilization review. Understanding these allows you to predict a plan's behavior. Looking back, managed care's legacy is defined by four things: enforcing cost discipline, shifting to prevention, ensuring coordinated care, and establishing the trade-offs between premiums and access. Thank you for watching this video.